All right, take it away, Dr. Kogan.
Okay, terrific. So for those of you who are able to join tonight, thank you for doing this. I based this a little bit off of the talk I gave to the residents previously, and so we'll show some of the more basic kind of cases that I showed to them. I think you'll have the Peds fellows will have a lot better answers to these, and we can move along quickly. And then I've got some more interesting and maybe a little more complex cases. It's definitely a case of audience participation. So I'm going to ask you guys to type into the chat window some of your answers when I ask you some questions. So we'll talk about some case-based learning. Of course, I have no, hard to have conflicts of interest in this sort of a topic. I wish I did, but I don't. And we're going to start with a couple of babies that I saw not that long ago with abdominal masses. So this is going to be the first case. It's a KUB, of course, of a baby with abdominal mass. I think you can see that clearly. And so my first question for you is differential diagnosis of newborn abdominal masses. Can you give me a list of some of the organ systems that you're looking for when you see an abdominal mass like this? Just anyone who's on, just type something into the chat box. I'll give you a few seconds. Nobody wants to do it. You can blind your name. I don't care. Just give me a couple ideas. I'll actually give you the first one. We're gonna make it easy for you. So about 50% of newborn abdominal masses are renal, and you know, hydronephrosis, multicystic dysplastic kidney, renal vein thrombosis, occasionally tumors, right? 50% adrenal, pelvic, etc. Okay, so that's this one. Okay, now I'm going to give you then, this is the same plain film of the abdomen, KUB, and this is a really ancient, one of the first DMSA scans. This is from my fellowship even, so this is more than 40 years old, but this is the DMSA. Can you give me a diagnosis? What does this child have? Just type it into the chat box. This is the plain film of the abdomen. This is the DMSA scan, very early DMSA. Tell me what you think this child has. Any kind of wild guess, even. Wilms is possible. What other things? Okay, you guys are a quiet group tonight. This is not going to go well if I have to tell you all the answers. So this is the same baby with a left retrograde pyelogram showing a massive UPJ obstruction on the left side and a second UPJ obstruction on the right side. So let me just go back for a second. Here is the cortex remaining from this huge UPJ obstruction on the left side. And this is the cortex on the right side with the hydronephrosis in between. Okay, so I'm going easy on you guys. These are just some standard routine cases. I'm not trying to like kill you on this stuff with rare stuff. Maybe later. Okay, how about this one? Here's a 36-week gestation girl, somewhat ambiguous genitalia. Here's the this is a plain film of the abdomen again. Remember we said most are renal, then there's GI, there's pelvic, there's adrenal. Okay, let's see what we got here. Okay, I'm giving you a hint here, think pelvic. Okay, there's a second hint if you need help with that. Anyone want to guess what sort of problem this patient has? It's a girl with ambiguous genitalia. Okay, here's the ultrasound pictures. Right kidney, obviously, left kidney. Here's the pelvis on ultrasound. Here's a uterus, it looks like they're outlining. Okay, hydroculpus, great, way to go. So this is a cloacal anomaly. And this is a girl with a cloacal anomaly that you can see here. The catheter on the cystogram went into this structure, which looks like vagina with the uterus above. And then anteriorly is the bladder. And here's a better picture, bladder, vagina, uterus above, okay? So she had a cloacal anomaly with hydrocolpus, as you guessed. This is after a vaginostomy. That's the only surgery she had initially to get her out of trouble in the nursery. Later on, she had a colostomy, reconstruction, etc. But this is the right kidney, left kidney, and the bladder now looks much more normal. You don't see the fluid collection behind it. Okay, and actually the day shortly before my last presentation to the residents, she came in for a follow-up. She was 7 years old at the time, voiding primarily by straining with mild stress incontinence, but basically normal, surprisingly normal kidneys, minimum residual, and continent of urine and stool for the most part. So she had a nice reconstruction. Okay, a third case of a baby with a KUB and abdominal mass, very distended belly. Take a guess of what you think this one is. I'm going to give you a hint. Look at the bowel gas pattern. So in each of these cases, I think if you follow the bowel gas pattern, there's obviously an abdominal mass down here, but there's also something pushing the bowel to the center of the abdomen in this case. So any idea, 2-month-old boy, we'll say, came in with sepsis. Now remember we said 50% of the cases of this are urinary. So anyone take a little guess at this one? Differential diagnosis of neonatal ascites. Here they are, urinary, bowel rarely, cardiac rarely, liver sometimes. Differential diagnosis of urinary ascites. What would you think in a newborn? Anyone take a guess on the chat box? How about this? Really very minimal, mostly, almost always posterior urethral valves, exactly. And then occasionally you see, and it's less common nowadays, but we used to see not infrequently an umbilical artery catheter gone bad that caused an injury to the bladder, and you got urinary ascites that way. That's much less common nowadays. So it's going to be valves. And the treatment, hopefully all pediatric urologists should know this. Okay, a catheter, right? And in Australia, if you lived in Australia, you might choose a suprapubic cystostomy tube, but most all of us in the US would put a catheter in the baby, drain the bladder, drain the urinary system, and see if the child got better, which indeed is what happened. This is interesting. This is the ultrasound. So you can see the right kidney here with the ascites surrounding the right kidney. You can see the left kidney here, both have significant hydro, and you see this very distended, abnormal, thickened bladder in the pelvis. So this was indeed, we thought, a case of urethral valve. So I have one other question for you. Can you tell renal function from a renal ultrasound? It's somewhat of a trick question, I'll ask you. Anyone want to venture a guess, yes or no, in the chat box? We have a very quiet group today. Can you tell renal function from an ultrasound? So I'm going to say, of course, renal ultrasound is not a functional test. Absolutely 100% not a functional test. On the other hand, there are hallmarks of dysplasia, and they're hallmarks of good renal function on ultrasound. So when I look at this, even this hydronephrotic kidney with urinary ascites, I see some corticomedullary differentiation up here, right? I don't see cortical cysts. I'm not seeing a super echogenic kidney. Same thing on this one, not very echogenic, no cortical cysts. So I'm going to guess, even though you can't tell, it's not a functional test, I'm going to guess that this is going to have, both of these kidneys are going to function pretty well. And I'll just show you, this is the cystogram in this patient. You can see the bladder, the very dilated, elongated posterior urethra. You can see the configuration of posterior urethral valves down here, and you can see the reflux to the right kidney. So no question that this is the diagnosis. Now I showed a couple cases of valves, and I want to show you the alternative, the neonatal voiding dysfunction here. So here you see the elongated posterior urethra, very dilated with this configuration at the bottom, pretty much the same here. And then you can see the neonatal voiding dysfunction. So this is not a trabeculated bladder, it's a smooth bladder. There's some dilation of the posterior urethra. And if I showed you multiple images, you might see this narrowing of the sphincter, which probably represents very high pressure voiding in the neonate. So I think that neonatal voiding dysfunction is different than valves and quite distinct on the cystogram. Okay, let's see if I can get this here. Okay, so why is it hard to put a catheter in? Because sometimes we do struggle getting a catheter. A lot of residents struggle getting a catheter in. And I think the issue is not the valves itself. And it's not that there's a narrow bladder neck, but I think the bladder neck is normal and you have this very dilated prostatic urethra. So the catheter gets lost in here. And a couple tricks that I like to teach my residents is firmer is better so that you can maneuver the catheter in here. The bladder neck is the problem, so you play around with a little bit. You might even try a coude sometimes. And of course, many people have written the literature to avoid a balloon type of catheter because one is the lumen of a balloon catheter is much smaller because you have to make room for the balloon. And secondly, because these are tend to be very spastic bladders, and you can contract your bladder right around the balloon, and you can get anuria actually from using a balloon catheter. Okay, so let's move on here. And that's the bladder neck, I think, is the problem in those. Okay, so we all know Hugh Hampton Young defined the 3 types of valves back in, I think, maybe 1918 or so. We give him an awful lot of credit because he didn't have cystograms like we have now. He looked at mostly pathological findings to try and figure this out. And of course, what type of valves do you think are most common? Of the 3 types that Hugh Hampton Young described, which are most common? Type something in the Zoom box if you would, anyone? Someone just take a guess. What are the most common types of posterior urethral valves? I see a couple things here. Okay, so someone type 3, type 1. Okay, so type 2, we're pretty certain don't really exist. Those are folds in the posterior or prostatic urethra that are found when the bladder is so distended like that. So that's not it. So it's really type 1 or type 3. And when I was a resident, there was no question that type 1 was the primary type of urethral valve, and that type 3, the membrane, was quite rare. Now, it's interesting that in Australia, and by the way, this is how I tend to resect them. This is not my picture, but I like the right angle electrode. I get behind it, and I just basically pull it through. It disrupts the valve. The valve is kind of like a sail. And you know, if you disrupt the sail, you don't have to destroy the entire sail, but once you disrupt it, it won't catch the wind. And the same thing happens with these. I like to do it at 12 o'clock first, which is not shown in this picture. And then I do 5 and 7. But once it's disrupted in any one place, it gets a lot more looser. And that's why I do 12 first. And then it's attached to the viru at 6, of course. So then I can still do 5 and 7 to disrupt it a little bit further. But that's how my philosophy, but you can do it anyway. But there's a guy named Paddy Dewan. You probably have heard of him. He's in Australia. He had this cool idea that instead of putting urethral catheters in, he would do a suprapubic cystostomy in these patients. And after the suprapubic cystostomy, he did cystograms through the SP tube, and he described what's called COPUM, congenital obstructing posterior urethral membrane, I believe is what it stands for. And what he found was almost all of his valves were type 3. And the theory is that when we put a catheter in this membrane, it went into the bladder, but it basically tore the valve in half, and it created what appears to be type 1 valves. So if you read Patty DeWan's work, it's really fascinating that all these years we've been thinking of them, and I trained and learned that these were all type 1. But I think, in fact, that most of them are probably type 3 that we convert to something that looks like type 1 when we put the catheter in. Really fascinating. Okay, a couple questions more about valves. What are the prognostic factors? This is something every Peds Urology fellow should know. What are the prognostic factors in patients with valves? Just list a couple. Anything that comes to mind. Okay, nadir creatinine is probably the most famous one and maybe the best one, of course, creatinine platinum, right. So I'll tell you that I think ultrasound is helpful. And when I showed you on that original ultrasound of cortical medullary differentiation, a lack of echogenicity, just normal echogenicity, no cortical cyst, that's going to tell me that that patient has a good outcome. Of course, in the literature, nadir creatinine, and it should be below 1, maybe 0.9. But remember, even 0.9 is a horrible creatinine for a baby. So that's about 3 times normal. So that'd be like an adult running around with a creatinine of 3. So a nadir of creatinine below 0.9 is certainly a good thing, but not always great. And the older literature that I grew up with showed reflux was also a prognostic factor. So reflux, if it's present on the initial cystogram, is bad. But even worse than that is after you resect the valves, if reflux is still present, then that's a really bad prognostic sign. So persistent reflux, probably because of an abnormality of the ureterovesical junction, not the reflux itself, but the embryologic bad ureteral orifice, bad ureteral bud, probably causes a dysplastic kidney. So the reflux, not the reflux itself, but the dysplasia associated with a bad ureteral bud. And of course, in older children, incontinence is a big problem. And remember, incontinence is a problem probably related to a bad valve bladder. And so we need to look out for bladder function. And that brings me up to the next question. What sort of bladder dysfunction do you look out for in patients with the so-called valve bladder? I'll give you a few seconds to think about that. What's the valve bladder look like? And of course, if you're super smart, you're going to type into the chat box, at what age are you talking about, right? Because there's 2 really types of valve bladders. One, early on, many of these children have high pressure, poorly compliant, very fibrotic bladders. But over time, probably related to polyuria, they tend to develop larger capacity bladders, and many of them can develop myogenic failure. So we really need to watch their bladder function really carefully in order to help preserve their renal function. Okay, and long-term outcomes, you probably know this part, but there's at least a 25, depending on what valve patients you're dealing with, 25 to 30% risk of renal insufficiency by early adulthood. So there's these kids really have a questionable prognosis, but you can interact with that prognosis and you can make it better by paying attention to their bladder dysfunction and making sure that they're emptying regularly, et cetera. So the reason I show this case when I did the resident lecture was this is the kid, I saw this kid 12 years after his valve ablation, and this is what he looked like at age 12. Remember that kidney looked so horrible? This is his right kidney, same kid, left kidney, same kid, some caliectasis still, but no significant hydro. But now he's got a big, huge, relatively poorly emptying bladder. And so fortunately, because his kidneys are good, and this is a low pressure bladder, it's not really affecting his kidneys, but he needs to be watched closely because he's He's on the edge of retention all the time, and so we watch him really closely. He's not willing to catheterize at this point, and he doesn't need to at the moment. His renal function is good, but he's right on the verge of getting into trouble, so we watch him very closely. Okay, I want to show this one. This is a totally different patient with valves, and this is a diuretic renogram. It's a rather old one. It's actually a UCSF diuretic renogram, believe it or not. And these pictures are every 5 minutes. So this is the injection. This is 5 minutes, 10 minutes. The diuretic was given at 15, 20, 25, 30, 35, 40, 45, 50, 55. Okay, so can you tell me what syndrome this patient has? That's the big question here. What syndrome, based on this renogram, done 6 months after his valve resection, what syndrome? Type into the chat box what syndrome this patient has. I really need your help with this. Otherwise, I'm going to get tired of talking the whole time. Anyone think of what syndrome this patient has? Let's look at the renogram. So this is the 5-minute picture. Notice that almost all the function is in the right kidney. These are posterior images, very little function in the left, right? We give the diuretic. You can see reasonable drainage from the right kidney into the bladder. This is an early renogram. We didn't always use catheters in the bladder like we should do, okay? So we're seeing this kidney draining, and it looks like kind of increasing function, if you will, on the left side. What do you think? Of course, that's not function, right? That's reflux. So you have a poorly functioning kidney with marked reflux. This is an, if you will, this is an indirect cystogram. Nobody does these anymore, but we used to do occasionally indirect cystograms to avoid catheterizing patients. But this is an indirect cystogram. So you're seeing marked reflux. Here he is voiding into his diaper, and you're seeing marked reflux up top. So what syndrome is this now? Anyone? Want to type in the syndrome? Right, this is VERD. This is valves, unilateral reflux, and dysplasia. And there's some controversy now, but most of us believe that actually this unilateral reflux and dysplasia caused by a bad urethral bud and a bad kidney developing on that side probably protects the good kidney and the bladder from really severe dysfunction. So in its own way, it's actually probably beneficial. There's some controversy. Some people don't believe it, but in my experience, I'm a believer that VERD, valves, unilateral reflux, and dysplasia, is actually kidney protective. Okay, so we've gone through a lot. I want to talk about a couple other diseases now. So tell me what you think of this ultrasound. This was a 1-day-old prenatal diagnosis of bilateral cystic kidneys. This one is right, this one is right, and this one is left. Tell me, what do you guys think? Anyone have a diagnosis to this? I'm going to make it relatively easy. Let's give you that this is a normal left kidney. You can see the pyramids here nicely, nice cortical medullary differentiation, minimal middle fluid in the pelvis. So this is a normal one. But this one, yes, multicystic dysplastic kidney, absolutely, totally 100% agree with that. Okay, now, since you made the diagnosis, couple questions. What further workup do you need to do? What further workup is necessary in these patients? Okay, someone said conservative, regular sono. All right, so I'll tell you my bias, and I'm a little extreme on this, but let's see what I can do here. Hang a second. Okay, do you need an ultrasound, VCUG, DMSA? In my opinion, 0. I'll explain why in a minute. What follow-up is needed? In my opinion, a blood pressure periodically can be done by the primary care doctor. a urinalysis to look for early proteinuria, which would be very rare. And the AAP recommends no contact sports, no major contact sports. That's a little controversial. Obviously, the whole discussion over 2 kidneys, 1 kidney. Of course, you only have 1 brain, so the argument is always, you know, if you play football, you're more likely to get a concussion than damaging your kidneys. So, but the AAP does say no contact sports. Now, someone said micturating cystogram. So would you do a micturating cystogram? So there is about a 10% rate of reflux in the contralateral and the solitary good kidney, but we almost never see any urinary infections. So whether you would find reflux and then put the child on prophylactic antibiotics, highly, highly controversial. And so we gave up. We used to do it all the time, and there's no point in doing a cystogram. Someone said follow-up ultrasound. To what end? You have a normal kidney on one side. We know that the multicystic dysplastic kidney involutes. And I know if Larry Baskin were listening, he might disagree, but I don't really care if it involutes at 6 months, 1 year, 5 years, 10 years. Scientifically, it's fascinating, but not really any. Well, someone said, good question. How do we know it disappeared? I got to see the whole question. Let me hang on a second. How do we know? So how many adults have you ever seen with a multicystic dysplastic kidney? And the answer is nobody that I know of has ever seen a multicystic dysplastic kidney in an adult. So virtually every one of them must involute over time. It just doesn't exist. You don't see it in adults. You don't see all the CT scans we do that come up with random little small renal tumors in the kidney. You almost never see. I've never seen a multicystic dysplastic kidney turn up. So I think they all involute. The long-term outcomes are uniformly normal. These kids just don't have any trouble. There is kind of a bonus question with this one, and this comes from my old days when I was a young faculty person. Is there compensatory hypertrophy in utero? So we like to think that the placenta does most of the work in utero, and so it's a really interesting, fascinating question. Would you get compensatory hypertrophy? And the fact of the matter is you do. So it's really exciting. There's some interesting papers. Jim Mandel was one of the main authors on one that looked at renal growth in utero. And in fact, there is some compensatory hypertrophy even in utero. Okay, then another question, how do we follow for the little chance of malignancy? So the chance of malignancy is minuscule when you compare to the number of patients with this. And we also know that the malignancies occur, if you did an annual ultrasound, the malignancy, if it occurred, would very likely occur within the year, and you'd never be able to diagnose it. So because malignancies are vanishingly rare, you would probably have to do an ultrasound monthly or quarterly at the least to try and pick up those extremely rare malignancies. You do thousands of ultrasounds, and you might even miss, you know, in this mess here, you might even miss a small malignancy. But I think they're extremely rare. You hardly ever see them. They're reportable. And I think you're probably doing overkill to do annual ultrasounds in these kids. Okay, let's move on. Okay, this actually is, I don't know why. I think because there was minimal hydro on this side, I think my nurse practitioner ordered an ultrasound, or maybe I ordered an ultrasound. And this is what that multicystic dysplastic kidney looked like even in 4 months. And there's a reference if you care. Okay, how about this case? This is kind of a cool one as well. So this is a tomographic DMSA. We tend to do tomograms here, but I tried to show you, I don't know if you can see my chat box if it's blocking it, but I want to move that so it's not blocking it. But here's an enlargement. Can you see that enlargement, or is it being blocked? Let's see. Here's the enlargement of one image from it. Anyone want to come up with a diagnosis? Well, it's the diagnosis here. Yeah, a duplex system. Perfect. Brilliant. Good pickup. Remember, so this is a really interesting topic in my mind because Let me minimize the chat a little bit here. I made it bigger, sorry. Okay, so two questions. One is, before we get to some of these things, which is better for picking up renal scarring, DMSA or ultrasound? Well, here's the ultrasound, and I think you can tell this is a thin parenchyma, very abnormal lower pole compared to the upper pole, but it's pretty subtle. You'd be surprised at how many people might miss that on the ultrasound. The DMSA is incredibly clear-cut. So I think there's no question the DMSA is much better than the ultrasound for renal scarring. And then let's see if I can do this here. Why lower pole scarring? So if you follow Ransley and the Big Bang Theory, and you know about reflux nephropathy, remember that intrarenal reflux is the key to scarring, at least in theory. And intrarenal reflux primarily occurs at the upper pole, so that if there's going to be scarring, the first place of scarring is almost always the upper pole of the kidney. And then later on, maybe mid-pole, maybe lower pole, maybe other areas as well, but the first place is upper pole. So if you see an intact upper pole with renal scarring, it's almost always a duplex kidney. Okay, and there's the cystogram on this patient too. You can see the lower pole reflux. Remember, and this is another case of, this is bilateral lower pole reflux, bilateral duplications. Remember, you're missing the calyces up here, your axis is off, and you have the so-called drooping lily sign, and that's when you see lower pole reflux, and that's the only time when you're really going to get lower pole scarring alone. Okay, there you go. Okay, and I love this article. It's a classic about the pathogenesis of reflux nephropathy. Ransley did a lot of fantastic research. Wasn't very good at writing it up, but he did a lot of tremendous work on this. Okay, quick question, and we'll go back to the chat. These are two newborns with non-palpable testes. I think this is an easy one for you guys. Let's see. Pull up the chat for a second. I can't seem to get it to the right size. Give me 1 second here. Okay, prune belly, of course. Good diagnosis. So this baby has such a big belly, doesn't even fit on the x-ray table. And this one, of course, has the urachal diverticulum and the very abnormal posterior urethral, posterior urethra, right? So very good. Okay, you all know this, the abdominal wall deficiency, Eagle-Barrett syndrome, triad syndrome, a lot of different names for this. Now, this is a typical voiding cystourethrogram, and notice it's very, very different than the posterior urethral valve. So it's a very dilated posterior urethra, but you don't have that configuration down here of the valve. So there's probably not an actual obstruction, at least at the time that these children are born. Okay, here's I was trying to bring this distinction. Here's what the valve urethra looks like. Here's what the prune belly urethra looks like. Okay, very different. Okay, how about this one? Here's a quick one. I won't spend too much time on it. Tell me what you think of this kidney here. Prenatal hydro, born at 30 weeks, a little bronchopulmonary dysplasia. What do you make of that? You see that same thing here. Anyone want to guess? So this is early nephrocalcinosis. We used to see this a ton, but our neonatologists have gotten a lot better now. This is usually associated, okay, I gave you the diagnosis already, due to, what's it caused by? Prenatal babies with bronchopulmonary dysplasia. They're usually put on furosemide. They get a lot of calcium supplementation, and they get an early nephrocalcinosis. What you do is you switch them to thiazides, or usually when they're older, you can take them off. And this is one of the few calcium stones that actually dissolves. And I'll show you on this one. Here, the same patient at 4 months of age. You can see much, much better. A little tiny bit of nephrocalcinosis remaining in the left kidney, but markedly improved merely by stopping the furosemide when you can, or if not, switching to thiazide diuretics. Okay, nephrocalcinosis in children, when you see it, think of hypercalciuria. Distal RTA is another big one. These others are much more rare. So you're going to think of these two primarily when you see nephrocalcinosis. Okay, how about this one? This is an ultrasound of the left kidney. Diagnosis, anyone? Give me a little help here. Okay, VUJ obstruction. Good thought. So this is, I made up a rule for my residents. I haven't patented it, so you can all have it accessible. There are only two possibilities when you see this picture. So you see a normal lower pole, excellent corticomedullary differentiation here, normal pyramids, and then you see this marked upper pole with a huge dilated ureter. Only two possibilities it can ever be, urethral or ectopic ureter. Those are the only two things that makes it really simple. Okay, so here's one case. Here's this same case. Here's the cystogram on this patient. And notice that you don't see reflux into this massively dilated ureter until they're voiding. So only when you see the voiding into the posterior urethra and you see the ectopic ureter here connecting to the posterior urethra, that's when this reflux shows up. And then you can get a DMSA and say, well, is it salvageable or not salvageable? And that will help you figure out what you want to do in terms of therapy for this. Okay, what to do? Okay, here's another one. Here's another relatively normal lower pole, big upper pole cystic lesion. Here's the bladder, and it's a little more subtle in this case, but there is a little sort of filling defect in the bladder. And when we do the cystogram in this patient, you can see the filling defect from the urethral. A couple of VCUG tips. Most of you are at excellent children's hospitals, but in the future, you may not be. So you will always want to get a very early film when you're looking for urethral before the contrast is too dense. And you always want to get a voiding film in a girl because you can see this urethral either extends down the urethra or is prolapsing into the urethra. And you want to get multiple voiding films to see it better. Sometimes the reflux only shows up on the second or third voiding film. So a couple of tricks that you should keep in mind when you don't have the world's greatest radiology. Now, we have a few minutes and I'm prepared to stop anytime, but I thought I'd do what I call quick hitters, so just show you a quick case. You tell me the diagnosis. It brings up the fact that baseball season, this is my favorite team, Wrigley Field and the Cubs, and you can see there's nobody in the stands on opening day. Very bizarre. Maybe we should shut down baseball, that's another question. Okay, here is an interesting case, a 1-year-old we saw. This is the ultrasound of the left kidney. This is the CAT scan of the left kidney, and I even gave you the pathology. So what's your diagnosis? Please type in the chat box. Someone says Wilms tumor. Could be a Wilms tumor, and sometimes there are tiny pockets of Wilms tumor in this huge mass. Yeah, so this is a multilocular cystic nephroma, right? A multi-cystic nephroma, I think. We call them multilocular cystic nephroma. Good guess. Wilms tumors certainly could occur, but this looks a little different to me than that. I think it's not, this kind of sort of appearance is more like a multilocular cyst. Okay, great. Okay, how about this one? Intermittent left flank pain. This is the retrograde pyelogram we did in this patient with intermittent left flank pain. Someone wrote crossing vessels, UPJ obstruction, but look at this thing right here. So this is a polyp that's flopping in and out of the UPJ. Many people don't do retrograde pyelograms anymore, and if you don't, you could miss a lesion like this. We still like to do them. I don't know if it's more for resident practice, but we get a nice retrograde polygram. You see that filling defect, and you know a different cause of UPJ, and you want to make certain that you excise it. Well, how about this one? This is a newborn I saw sent to me for a hydrocele, but it didn't transilluminate. When I tried to transilluminate it, didn't transilluminate, so I got an ultrasound. This is what the ultrasound looked like of that lesion. And this is very hard to see, but this is a KUB. You can see there's some calcification in the scrotum. And if you look up here, there's actually some calcification in the abdomen. So anyone want to guess what this is? So this is actually meconium periorchitis. So this child had meconium peritonitis, had a patent processus at the time. The meconium went down into the scrotum. It gave you this ground glass kind of echogenic appearance. You saw calcification here, and you can't see it well on this KUB, but there's calcification in different parts of the belly. So yes, this is an intrauterine gut perforation. It could be associated with cystic fibrosis. This child didn't have that, and it was just one of those random cases. And I don't know if I showed you the follow-up. Yeah, this kid I saw about 6 months later, and the whole thing had scrunched down to this little calcified nodule. So this was a meconium periorchitis, kind of a cool thing. Okay, this girl, this is actually an interesting case. When I was in San Francisco, this girl from San Francisco had gone to Minnesota on vacation, went into urinary retention, and the hospital in Minnesota put a catheter in and did this cystogram. What do you think this one is? Rhabdomyosarcoma. This is a sarcoma botryoides. It rarely presents with hematuria, as you would guess. It almost always presents with retention. And this would have been the ultrasound. This was not the same patient, but this is what it would look like on an ultrasound. This is what it looks like on pathology with these nodules of sarcoma botryoides. Way to go. Okay. How about this one? This is fascinating. Hillary would like this. This is one of the first MRIs ever done. I was at UCSF. They had this new gadget. We saw a kid with an abdominal mass, and they said, hey, let's get an MRI in this kid. So this is one of the first MRIs ever done. These are obviously coronal images, and this is what the histology looked like. Right, and this is definitely a Wilms tumor. The triphasic histology of a Wilms tumor, which you see there, and multiple nodules of Wilms tumor throughout both kidneys. This child we put on chemo, we biopsied, put on chemotherapy, I think this kidney wound up with a nephrectomy. I forget which one. One had a nephrectomy, and the other we were able to do partial nephrectomy on and save the child. Okay, here's a quick one, really quick one, and then you guys tell me, is it necessary to do a biopsy? Good question. Classically, yes, and the reason people give for that is to see if it's favorable histology or not, because you might change your chemo and give much more aggressive chemo if it's unfavorable histology. But frankly, I'm not really sure it's necessary to do the biopsy. I think almost all the cases of bilateral and that nodular appearance are usually favorable histology. But technically, we're supposed to do a biopsy on those. Okay, what do you think of this diuretic renogram? These are the time activity curves from a diuretic renogram. You all look at a million of these all the time. What would you call this one? Obstruction, no obstruction, maybe obstruction. What do you think? Either kidney, they both are performing at about the same here. Someone tell me what you think of this diuretic renogram. No obstruction, correct. So this is very dilated, but non-obstructive system. So the normal renogram shoots up like this, starts to drain even before the diuretic, and then the drainage is accelerated. This is a very prolonged uptake curve. So these are both hydronephrotic kidneys. But once you give the diuretic here, you can see excellent washout of both sides. So these are both dilated, classic dilated, but non-obstructed kidneys. Okay. And if you have time, I've got a couple more. This is a newborn with bilateral hydronephrosis. Here's the pelvic image of the ultrasound. Here's the cystogram image. And if you wanted, here's the MRI. Was really not necessary, but for fun, we showed it. I don't know if you can see that there. So what do you guys think? Let's minimize this one, make it smaller. Okay, so hydroculpus, right. So if you look closely, here is the bladder. You can easily get fooled. This is posterior to the bladder. That's your vagina. Here, this is a beautiful image of the urethra, very elongated, the bladder, the vagina, and the common urogenital sinus. So this is a common urogenital sinus. The vagina comes off here. Every time this child voids, more and more urine accumulates in the vagina and distends it, etc. So common urogenital sinus, very easy, turned out to be a very easy repair. We did a little flap. You have a very long urethra here, so we did a little flap, perineal flap, opened this vagina up, and it solved the whole problem. Okay, here's a cool case. Also from my days in San Francisco, this patient was operated upon by Frank Hinman. Some of you may know him, very famous urologist and pediatric urologist when I was growing up. And he did a hypospadias repair on this patient. And he had a stricture. I saw him to try and take care of his stricture. And we did a retrograde urethrogram. You can see the urethra here, not very well on this picture. And then we did this, in those cases, we were doing IVPs. He has a horseshoe kidney. I'll give you that one. But he also has the bladder here and this lesion. Right, so this is the prostatic utricle. It looks an awful like a vagina, uterus, and fallopian tube, right? And it turns out that this patient had, well, we called it a true hermaphrodite in those days, but now we say ovotesticular disorder. So he had both ovarian tissue and testicular tissue, and he had this huge Mullerian remnant that wasn't usually a problem, but became a problem with the stricture. So when he voided with the stricture, a lot of urine would tend to accumulate here. He had infections and pain. But I thought it was a fascinating retrograde urethrogram. Okay, we'll do a couple more because I know it's getting late. I thought this would be an interesting one. This is a very poor quality ultrasound, but it makes kind of a key point. This is right hydronephrosis diagnosed prenatally. This is the postnatal ultrasound. We talked about renal function. Guess how much renal function this kidney would have if we did a diuretic renogram or a DMSA. Give me some idea what you think the renal function would be. Right UPJ obstruction is correct, but how much? Give me some idea of the right renal function. 10%, 20%, 50%, 40%, 40%. Not bad. Okay, here's the DMSA on that patient. 0%. Why do I say that? You have cortical cysts. See these little cortical cysts right here, 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 here. And you have very, very echogenic parenchyma. Here's the liver. And even in the ultrasound, you have a more echogenic kidney by far than the liver. You don't see any cortical medullary differentiation. So my point is, ultrasound is not a functional test, but you can tell renal function from an ultrasound if you look really carefully. So keep in mind when you look at an ultrasound, cortical medullary differentiation, echogenicity, and look for cortical cysts. And you can get some idea of renal function on that. Okay, I have a bunch more, but let me show you one more and then we'll quit. Give me a diagnosis on this one. 3-year-old boy with hypertension. Move the pointer. Anyone come up with a diagnosis? Neuroblastoma, absolutely. So this is a huge mass, crosses the midline. Actually, the kidney itself is normal here if you look closely, right? And Wilms tumor patients tend to be mostly asymptomatic. They get these large masses and they walk in and they look like normal, healthy kids. Neuroblastoma kids are sickly, they have hypertension, they look sick, and they have they can have these huge masses across the midline, encasing the aorta in this case. Really bad case. Okay, I have more, but in the interest of time, let me know if, why don't I just close this, and I'm happy to take questions. See if I can do that. Oh, can I show you this? Let me show you this one. This is not an x-ray case, of course, but I found this at an orchiopexy. Okay, here's an intraoperative photo. Let's see. Here, obviously, is the testicle, this little nodule, ectopic adrenal tissue, and there's the path, right? Way to go. Okay, I'm going to try and get out of this now if I can. Thank you for paying attention. I am happy to take any questions. Let me see if I can look at the Q&A. If you have any questions, I'm happy to do it, or I'm happy to look at the chat, take questions, and enjoy doing it. I hope you guys got something out of it. Anyone have anything? All right, you're very welcome. I appreciate that you guys enjoyed it, paid attention, and thank you very much. Hillary, should we end it here?
That's great,
Yes.
Barry. Thanks so much.
Okay, my pleasure. And next time, I still have about 7 or 8 more cases. We can do some other ones next time.
Oh, if you have more, you can finish the time. It would be fine, or we can.
Okay, want to
like.
do, if you guys want to stay on, I've got a couple more cases. We can do that. And now you just, let's go from current slide. Okay, let me just do a couple more because there's some interesting ones. This is one of my oldest cases. I was a resident at University of Michigan, and a prisoner came in. This guy was in the state prison. He complained of abdominal pain. This is one of the first CAT scans ever done, believe it or not. This is his intravenous pyelogram, which we did all the time in those days. And you can see this kidney is lower, this kidney is higher. Here's his CAT scan, and you can see it's a little calcified. There's this lesion above the kidney. Anyone want to guess what that is? 15-year-old. It's an adrenal mass, absolutely. And this was a ganglioneuroma. Okay, so neuroblastomas mature into ganglioneuromas mostly. The majority of neuroblastomas are not clinically relevant. We know that because in Japan, they used to do screening for neuroblastomas, and they found way, way, way more neuroblastomas than the number of kids who presented with neuroblastomas. And most of them mature into ganglioneuromas, and that's what this kid had. His abdominal pain was totally incidental. He was trying to get out of prison, and but it was really a fascinating case. We wound up taking it out, but we didn't have to. We didn't know any better in those days. Okay, how about this one? This is cool. 2 cases, same diagnosis. This is a newborn who had prenatal hydro. We couldn't get a catheter in, so we put an SP tube in and did this cystogram. Here's his bladder. Here's his posterior urethra. Here's his anterior urethra. Tell me what your diagnosis is. And then this is a 14-year-old who I got totally fooled, came in with post-void dribbling. I wrote him off. I said there's nothing wrong. Anyhow, the local urologist got a cystogram on him, and this is what it showed. So this is, right, this is anterior, these are both anterior urethral valves. So this is a huge urethral diverticulum. Here's the urethra here, and then you got this huge diverticulum. And this kid also has an anterior valve, a urethral diverticulum. So these are anterior valves, urethral diverticula. This is how we took care of this kid. We actually had he was a big kid. He was like a 15-year-old. So we were able to get a cold knife in and open that diverticulum wide open, and that cured his post-void dribbling. So I was totally fooled and totally wrong on that one. Okay, here's and like in the last 2 minutes, let me give you these couple. This is a newborn who died from pulmonary hypoplasia. This is the pathology on that one. You can see these things here. Okay, there are bilateral, it could be bilateral multicystic dysplastic. Yes, it was Potter syndrome, true. But, and so polycystic kidney disease, can you tell me what type? What type of polycystic kidney disease? And what associations do you look for? So there's recessive and dominant, right? So this actually is autosomal dominant polycystic kidney disease. These are multiple cysts in both kidneys. It's also associated with what associations? Cysts in the liver, cysts in the epididymis, and hypertension and barrianeurysms. Okay, just to be quick, because I know it's late, I want to show you a couple more. What is this fetus with oligohydramnios? I gave you a big hint, huge echogenic kidneys, fill the abdomen. This is autosomal recessive polycystic kidney disease. These are big, huge, spongy kidneys that fill the abdomen. You don't actually see cysts in these cases. And if you look at this autopsy, also of autosomal recessive polycystic kidney disease, they're big, huge, spongy kidneys, and they have what in the liver? Periportal fibrosis. So this is autosomal recessive. We used to call it infantile and adult type, but as I showed you, you can have adult type or autosomal dominant in newborns, and you can have infantile. I didn't show you a case. I have a case of infantile, so-called infantile or autosomal recessive, presenting mostly with liver findings and not kidney findings. Okay, I'm going to wrap it up. Thank you so much for your attention. I hope it was useful. I hope it was a nice review of a lot of different pediatric diagnoses. And you guys have a great day and great evening. And thank you for listening. Thank you for inviting me, Hillary. Appreciate it. All the best, everyone. And I think I'll sign off here if I can figure out how. Oh, this is our logo for 2020. All the best.